I'm going to shift gears now, and I want to bring up my colleague and friend Bruce Buckingham, and he's going to tell you about some very exciting work that he's been doing to try and mimic the beta cell. And I'll let Bruce attach his computer here. Go ahead and hop in there. So Bruce is actually a Southern Californian at heart. Born and raised, and I don't know about born, but definitely raised. Let me trace your academic journey. Can you get in here as I'm talking? So Bruce is a graduate of UCSD. He then did his residency and fellowship at Children's Hospital Los Angeles, and has come north now. Has been on the faculty at Stanford at the Pancreas Children's Hospital, and is a professor there. And he has really been a pioneer in trying to move forward with closing the loop. How can we critically evaluate sensors, have them communicate with pumps, and really develop an artificial pancreas? And he's an investigator in a variety of different networks, including DirectNet. He's a very close partner in the TrialNet efforts that I've referred to. And he has the unique claim of proposing a study that was voted unanimously to be done by TrialNet. And that's a very hard network to build consensus in. So I'll let Bruce take over here.
Thank you very much, Steve. It's a great pleasure to be here, and I'm truly excited to be invited up to the UCSF group. I just want to re-emphasize what Steve has been talking about with TrialNet. This is a really important way to really make advances that will potentially help your children, but also help future generations. And just to sort of paraphrase an old president, ask not what diabetes research can do for you, but what you can do for diabetes research. And the mouse has been cured about 200 times now. And not one of those has really cured a human being. You really need to study diabetes. I don't know about the lactating mouse versus a cow's milk mouse. I have to check that out. Okay, so I'm going to talk about an artificial pancreas, but what I'm going to try and do is put a lot of sort of the practical things we've learned, things that you may be able to use on a day-to-day basis, as well as sort of the theoretical stuff. And I'm not going to talk a lot about the algorithms per se. If you want to talk about that, I can talk afterwards later with you. So this was diabetes in 1923, before insulin. And they say insulin isn't a cure, but for this kid, this is a year later. Big, big difference. And insulin is not perfect, but it is a lifesaver. The problem with insulin, it has a very low therapeutic margin. If you give too much, you end up with very severe low blood sugars. You give too little on a long-term basis, you end up with these chronic complications. But I want to point out, when I started out, I'm an old guy, so it was about 30 years ago, and a family was diagnosed with diabetes. We would tell them, you know, it's a 50% chance in 20 years you're going to be in kidney failure or have blindness. The data today is, after 20 years, it's a 1 or 2% chance of having those complications. We have better insulins, we have better ways of delivering it, we can monitor blood glucose levels, then they were doing urine tests, and all these technology has just made a huge difference. So the future is much better. So for an artificial pancreas, you're going to need a pump, a sensor, and an algorithm to integrate them and control them together. This is the first pump I wore. And wow. Do you know who made this pump? Dean Kamen, the guy that made the Segway. And this, go to the next. It's not advanced. So this is a pump that Dean Kamen made for our current studies using in a closed loop system called the Florence system. So we have gotten a lot smaller, pumps have become more colorful, pink, many skins. These are all tethered pumps. And then you can have the Omnipod, which we just heard about, which is has an auto inserter. It's a patch pump. There will be smaller, newer patch pumps. This is MEMS technology, and that's the whole pump. Whoops, let me go back one. And so this is actually a pump with 600 units of insulin. Empty, maybe the butterfly could carry it. With the 600 units. So there are problems with infusion sets. You get skin reactions, and there can be issues. It turns out 66% of patients have occlusions or unexplained hyperglycemia wearing insulin infusion systems, and they're approved for really 2 to 3 days of wear, where most of these sensors are approved for 6, 7 days of wear. So if we're going to integrate these two, put them onto a common platform, we've got to get the infusion set to last longer. And so when we think about this system, and you talk about the sensor and the pump and the algorithm, it's all the little components in here that need to work and be integrated together to really make, I think, a user-friendly system. So I'm going to give you, this is a typical thing we see where you see someone going along and you see their blood sugars go up and their insulin going up, and then you look down here and they change their infusion set, and then their blood sugars begin to come down, and then they're going up here, and then they change their infusion set and begin to come down. And this person's just waiting too long. They're waiting until they get a set failure before they change. This is one of the first things I look at when I look at a pump download. How frequently are they changing and what's happening to their blood sugars before they change? So are there insulins that would be better? How many think Novolog is better in an infusion set than Humalog? Okay. How many think Humalog is better? Okay. How many think Lysine is better? Okay. We got about a 12% response from the audience. How many here are their families or their children wearing an insulin infusion pump? This is technology country. I like it. So a lot of you just don't have opinions. Okay. So we took 20 subjects and we gave them either Novolog or Humalog, and we had them wearing an infusion set. Okay. And we asked them to wear it for a week until the infusion set failed, meaning the blood sugar was over 300. They gave a correction dose and it failed to drop at least 50, or they had ketones, or they had an infection at the site. So one of the things we did, we stained the catheters, and this is staining the catheter with dithiazone, and it picks up insulin crystals and precipitation, and every single infusion set, you saw this type of precipitation in the cannula. How many of you do this at home? But you can see this begins to look like an atherosclerotic plaque in the coronary artery here. You can see flows sort of going down. And this is the answer. There was no difference between Novolog or Humalog in infusion set survival, and there were about 40% of people that could wear the set 7 days. So, then we asked the second question. Does it make a difference if it's a steel or a Teflon infusion set? So how many think the steel infusion set is going to last longer? All right, there's Shirky people here. How many think the Teflon set is going to last longer? A little more committal here. Come on, guys. Make go one way or the other. Okay. Great. So this is the steel Shirky, and this is a Quickset Teflon. They're equal length. This has a little connecting tube here. And again, the same thing. We had 20 subjects. This time we asked them to wear each infusion set twice in a random manner. We had 80 weeks of wear and asked them to wear it for a week or until it failed. And this is the glucose values. If there was a set failure due to hyperglycemia, this is the Shirky, and this is a Quickset. So you see some early failures with the Quickset, and then they're about the same the rest of the way. And those failures are due to a kink when you go in. So what is the, this is a tracing. And what we did was we had ulterior motives for doing this. Because in our closed loop systems, we want to be able to detect an infusion set failure before it happens. So we have an algorithm here which is looking at the probability that when you look at the amount of insulin being delivered and what the blood glucose is doing, whether you're getting ineffective insulin delivery. And you see we alarmed here around noon, and we alarmed here around 6, and around 10 o'clock at night the person realized their set had failed. So we could pick it up about 10 hours earlier with our algorithm. And here's another one. And this one is sort of interesting because it alarmed around 10 o'clock at night, again around 3 in the morning, and the person realized it had failed it when they got up the next morning. So this would have picked it up before they went to bed. You could fail due to erythema and induration at the site, and we had them measure this when they took the set out. And this is someone with about 3 millimeters of erythema and induration. And what was interesting to me, this is the blood sugars overnight, and despite that inflammation in that actually adolescent, there was no change in the blood glucose control. And it turned out the erythema induration only affected blood glucose control about 25% of the time, which erythema is redness around the site. So you go back here, see there's sort of that red circle around here. Induration is firmness. So where I put the pan here is where the tissue begins to firm. There's sort of swelling. There's a tissue reaction underneath it. Cut me short on all these, because we sort of have our own lingo here, and let me know about it. That's great. And so this is the overall survival between the two, and they were about the same, steel versus Teflon. About 40% could go to 7 days, and this was the individual. So some people could go 7 days consistently, and some people can only go 2 or 3 days consistently. So there's a real biologic variability between people. The people that could wear it, there were 25 weeks where they wore it 7 days, had no change in their glucose levels over that period of time. So there wasn't. So this is an individual biologic thing, and I think when you look at that interface where insulin's going in, that pumping isn't continuous. It stops, it starts, stops, and starts. And tissue proteins can go up there. Macrophages can actually go up there. I had a guy that's been cutting these up and looking at it, and when you get macrophages in there, it's sort of like, DNA snot in the middle of there. So we need, I talked about pumps and infusion sets. We need a sensor, and these are the typical, this was me at UCSB. You notice everyone wearing a sub-Q sensor has no sub-Q fat. You can get a fluorescent sensor if you have big ears. And this is one that goes under the skin and gets a little pellet implanted, and it'll last 6 months. So they're doing this. They did their initial trials in Europe for 3 months, and now they're going to extend it to 6 months. And you wear a watch over it, and it's like the tanning room, and you can see your glucose there. This is the mini-med system. And what are the problems? Well, there are time delays, the sensor has lag times, insulin has lag times, there's the accuracy of the sensor, there's biologic variability in insulin action, and most importantly, in meals. There's a huge variability in meals. Exercise is very hard on a closed-loop system because all of a sudden you get a very rapid change in insulin sensitivity, and you can't predict that. And it's hard to shut off the insulin in time. But one of the biggest, well, I will say, I won't call this a barrier. I'll just call it a delay. It's the FDA approval process. And it's been fun.